If women start to sleep poorly because they don't have enough progesterone and then they don't have enough estrogen, they start to fall down this hormonal flight of stairs. And that's what leads to a greater risk of cardiovascular disease, metabolic disease, immune system dysfunction. We want a woman to sleep well through this period because sleep is as close to a panacea as we have. It's when all the growth and repair hormones are made. It's when you recover from the damage of the wear and tear hormones, like the stress hormones, cortisol. So sleep is essential. When you treat with progesterone, it improves sleep and it has basically no adverse effects on your cholesterol or your cardiovascular health. So in my mind, there's no reason not to give it, especially if it helps a woman sleep.
Hi friends, I think as women, we struggle with so many different challenges during our lifetime, including hormonal health, things like perimenopause and menopause, but also, as my guest on today's show points out, we still have issues around things like a gender pay gap. And I think we have come a very long way in terms of success for women, but unfortunately, the reality is that women are under more stress than ever before, with more expectations placed upon them. And so in this week's episode, I sit down with Dr. Sara Gottfried for the first in a two-part series about how to optimize your hormonal health, how to manage stress, how to have optimal thyroid function, and also the impact of trauma on our lives. In this first part, we are talking all about hormonal changes, including the transition through perimenopause into menopause, and we also talk about Dr. Sara's best-selling book, The Hormone Cure. And then in part two, we talk about the effects of trauma and her brand new, incredible book, all about the autoimmune cure. So stay tuned for part two, but in this week's episode, enjoy part one. Let me now introduce you to the incredible Dr. Sara Gottfried. So, Dr. Sara, I am so excited to have you here today. I'm a huge fan of your work. Just absolutely amazing what you're doing and just transforming the lives of women around the world. Firstly, a very warm welcome to the show.
Thanks, Angela. Happy to be here.
Yeah, so lovely to have you here. I guess a good place to kick off when we're looking at hormones is, and we're looking specifically at sort of perimenopause and that transition through into menopause. It feels like definitely it's getting a lot more airtime at the moment, but it also feels like in the Western world in particular, women are having a harder time of things. And we've definitely got higher stress levels post-pandemic. What do you think, what in your experience, in your practice, are you seeing? What do you think is going on there?
Well, I think the pandemic definitely changed our biology, mostly not for the better. And I've been taking care of women with perimenopausal and menopausal symptoms for about 30 years. I feel like we're more dysregulated than ever before. And you could even see this hormonal transition of perimenopause and menopause as indicators of dysregulation. You know, the hot flashes, night sweats, mood changes, irritability, rage, anxiety. You know, there's more than 100 symptoms that women experience, and I think many of them are dysregulation. So what's going on? I think we've got a confluence of factors. I think that when you look at dysregulation, generally there's a trigger. Hopefully we'll talk a lot about triggers today. And I think for some people, an infection, like with the virus that causes COVID, can trigger dysregulation. But perimenopause alone and menopause are triggers. So is being postpartum. And the women who are postpartum and in perimenopause, they get kind of a double hit. So I really feel like what I'm seeing in my practice is more dysregulation than ever before. And it's related to stress response. It's also related to what I think of as the pine system. Your psychology is the P of pine, I is immune system, N is nervous system, E is endocrine system. So certainly your hormones are disrupted, but the entire pine network is affected.
And so do you think that's like why we see so many more symptoms in the Western world, for example? I feel like when I look at women, if I look at myself, for example, I'm 48 years old. And so, you know, I'm not far off going through that transition. And I look at the stress in my life and the women that I deal with. And I think that it's a unique period in a woman's life, right? It feels like there's a convergence of different things that are coming together at the same time, from, raising teenagers through to having, LG parents. I lost my dad a couple of years back. My mother's got dementia. There's this unique set of circumstances, I think, that's going on. Women are obviously often in sort of more high pressure jobs at that stage. They've got to a level of leadership, right, where they're responsible for other people. I feel like it's not just the hormones, it's everything else, right, that's going on there.
It's not just the hormones, you're right. It's a confluence of factors. So the ones that you described, which I think of as almost like a biochemical initiation, where we're going through this shift from being a householder, from having this role as, a mother, the daughter of aging parents. We've got this role change that's happening. And we're shifting from, kind of this daily management of all of the activities to more of a wisdom keeper role. And it can be a rough transition. So, yes, it's more than just your hormones. It's important to realize that perimenopause and menopause, just on its own, is not just a hormonal change. It's a major metabolic change. A lot of women notice weight gain, they notice more belly fat, they become more insulin resistant, and it's a major immune change. So the different parts of your immune system, the innate and adaptive immune system, are dynamically changing during this transition. And it tends to start, depending on how much attention you pay to it, around 35 to 40. So at 48, that's when a lot of these changes are in place already. And it's a lot to manage. And then, yes, we have more success than ever before as women in the marketplace. And yet we still face pay gaps. We still face a number of things in our culture that are toxic to us, that make being female a health hazard. And so I think when you put all of these things together, it ends up being a pretty rough period. Now, a lot of people pin that on their hormones, and that's part of the story. It's not the whole story.
There's a lot more going on. And when you look at the, you mentioned there about the immune system, and I know we're doing a part 2 where we're going to talk a lot about autoimmunity, but just to sort of introduce people here, what's going on in those perimenopausal years in terms of those changes to the immune system? What can women expect?
Well, it's a time when more autoimmunity occurs. Now, one of the things that I saw in my practice that made me start to look at this is that I was seeing more people, more women with vaccine reactions than I was seeing in my male patients. And so that got me to start looking at the different parts of the immune system. Why is this so? And it's a little hard to tease out what's the chicken and what's the egg, but we know that a lot of the sex hormones, estrogen, progesterone, testosterone, act as immunomodulators. So they help to keep the immune system kind of in check and balance. And so when you start to have wild fluctuations, and we can talk about what those are, the first phase of perimenopause is when progesterone is lower. And that leads to typically periods that are closer together, sometimes heavier bleeding, sometimes spotting, and then bleeding heavier the next period. So an unpredictability. So low progesterone is the first part of perimenopause. You can also notice more anxiety, difficulty soothing yourself, trouble with sleep. The second part of perimenopause is when estrogen declines. And in the first part of perimenopause, when progesterone declines, estrogen can fluctuate wildly. And so you can imagine with some of these fluctuations, with progesterone going down, estrogen fluctuating wildly, testosterone going down, then estrogen going down, this can affect the immune system because many of these hormones help to keep our immune system in a state of homeostasis. So in a state of equilibrium, kind of regardless of what's happening externally. And we also know, just looking at the data on men and women, that women survived COVID, at least in the early part when mortality was higher. Women survived better than men. And we think a lot of that is related to these sex hormones. So, what's happening with the immune system is that it's going through this pretty dynamic change. And when you think of it as this immune, metabolic, hormonal change after age 40, it helps to understand kind of the breadth of experiences that women are having, and also to get a sense of, okay, why is it I can't eat bread anymore? Why is it that it feels like I gain 5 pounds overnight when I eat more carbs? And, your body is changing. So after 40, part of the metabolic change, which is in concert with these immune changes, is that you are gaining about 5 pounds of fat each decade after 40, and you're losing about 5 pounds of muscle mass. And that makes your metabolism slow down. So unless you're doing something active to address this, that's kind of what generally happens. And your glucose becomes more dysregulated. So that's part of the story with insulin resistance as estrogen declines. So all to say that it's a challenging period that women are going through, and we need support. We need to be talking about it. I feel like perimenopause, menopause needs to be rebranded. We need to be a lot more honest about some of these changes that are happening, instead of, kind of the Instagram social media picture of, I don't know, a woman at 50 in a bikini and how she's like holding everything together just fine. We need to be talking about the level of dysregulation that we're experiencing. And one of the best ways for women to respond to these stressors is to tend and befriend. So just like what you and I are doing today, having these conversations, helping to regulate and co-regulate each other and the people who are listening to us and viewing us, that's what we need to do as women. That's how we lift each other up.
Yeah, I love that. I love that. Really kind of coming together and supporting each other. One of the things I wanted to ask you about alongside that is, when I was sort of doing some research into it, is that that going through perimenopause and menopause affects the mitochondria, and there's less mitochondrial DNA replication, right, which is affecting women's energy levels. Some of that I know from my fitness background. We can do certain types of interval training, for example, that can help to stimulate the mitochondria. We've got things like red light therapy. What have you found in your practice around mitochondria and energy for women?
Yeah, well, I test everyone that I see in my practice for mitochondrial function, because mitochondrial fatigue is so common, especially after age 40. And one of the ways that a lot of women feel it is when they exercise, they just feel really depleted afterwards or during. And so that's one of the key questions that I ask to check on the mitochondria. And as you described, you've got mitochondria in every cell. Most cells, not every single one of them, but most of them. And they're the powerhouse. They're what produce ATP, and that's the energy that you need to function. So if you've got mitochondrial fatigue, if you're not making ATP the way that you did maybe in your 20s, you're going to feel a deficit. It's going to feel like you're, pushing a rock up the hill. And I think a lot of women feel that. I did a survey of my patients a few years ago, and I found that 80% felt like their energy just wasn't what it used to be. About the same number had decreased sex drive. So all of these things, a lot of these symptoms track together, and they also had weight gain. So a lot of people experience this, and some of it is the way that you live, kind of the way that you eat, move, think, and supplement. Some of it is age, but I definitely see some people who are on the older side of things, but their mitochondria are just fine because they've paid attention to it. And then I see younger women who've got mitochondrial fatigue. And then we want to also think about these triggers, such as trauma, toxic stress. That's one of the things that really harms mitochondria. It causes swelling and dysfunction of the membrane of the mitochondria when you've experienced toxic stress and it continues to live on in your cells.
And by toxic stress there, do you mean emotional stress as opposed to toxins?
So, I mean a few different things. I mean, toxins certainly can lead to mitochondrial fatigue as well. I mean, by toxic stress, I'm talking about an overwhelming experience. So, an emotionally distressing, overwhelming experience. And there's a way that trauma is used so much in our lexicon now that it's lost some of its meaning. When I talk about trauma, mostly I'm talking about post-traumatic stress disorder or partial PTSD, subthreshold PTSD. Some people relate to toxic stress better. So here I'm talking mostly about emotional and psychological distress that lives on in the body in a stress response that isn't completed. So that's what I mean by it. And we could maybe talk separately about other forms of toxic stress, such as endocrine disruptors and heavy metals and that sort of thing.
Yeah, for sure. I definitely like to dive into that. I wanted to pick up on something you said there around earlier, just around like reduced sex drive, for example, and also I think reduced sexual pleasure. Many women seem to experience this alongside a lot of what I hear is urinary problems, right, as well. So like either kind of increased cystitis and things like that, infections, or an increased need to pee at night. What's going on there? Because I know this is bothering for a lot of women, and sometimes that reduced sex drive can be a function of high stress, right, and low
Yes.
energy. But I think it can be, there's some women I speak to, and they're saying actually it's not that I have reduced sex drive, I just have reduced sexual satisfaction, which is not nice. What's going on there?
It's complicated. So I'll start with the simplest part, which is uh, vaginal dryness, vaginal irritation, feeling like the nerves that go to the clitoris and to the labia are not what they used to be. Maybe you can still have an orgasm, but it's not as potent and strong as it used to be. So that is mostly hormonal. We definitely think that estrogen, testosterone play a key role in terms of keeping your vulva and vagina functioning normally. So the reduced pleasure, I feel like a zealot in some ways for treating this because there's pretty much no downside. There's the cost of getting some of the creams that we use. Systemic therapy, when you take hormones throughout your body, bioidentical hormones, also can help the vulva and the vagina. But we use this readily in terms of taking care of women, and yet there's still a lot of women who are suffering. So it's not just perimenopausal and menopausal women. A lot of women, about 20% who take the birth control pill, also have decreased pleasure, decreased libido, vaginal dryness. So that's a side effect of taking the birth control pill. It raises something called sex hormone binding globulin, and that soaks up free testosterone and can lead to similar symptoms as going through perimenopause or menopause. So when you have less estrogen and testosterone, you get thinning of the mucosa of the labia and also the vagina. And so that can lead to more irritation, especially with insertion right at the what we call the introitus. So that's a place where a lot of women feel discomfort. And then you get the same thing in the urethra, the opening, your pee hole. And that can lead to a greater risk of cystitis or bladder infections because bacteria can climb up more easily if the sphincter to the urethra is not working as well. So we know, for instance, that giving local estrogen therapy, so typically as a cream, estradiol cream or estriol cream, that's been shown in randomized trials to reduce the risk of developing bladder infections. You also mentioned another urinary symptom, which is nocturia, which is where you get up at night to pee. And conventional medicine, which I was trained in, basically says it's normal to pee up to twice per night. I think that's pretty disruptive to your sleep. So for most people, I'm trying to get them to pee once a night or less. So this is part of the same continuum. When you've got less lubrication, you don't have as strong a sphincter to the urethra because of loss of estrogen, loss of testosterone. You've got decreased sensation, maybe a greater risk of bladder infections, maybe less powerful orgasms. All of that is treatable with vaginal local therapy with either estrogen or testosterone or a combination of the two. There's also some new data that you can use topical DHEA, which is a precursor to testosterone. So this is a pretty easy thing to treat. I'm glad you started with it first because in some ways it's less complicated than are you a good candidate for taking bioidentical hormones through your whole body? We know for the vagina that even women who are breast cancer survivors can take it safely.
So it's actually an easier thing to treat. But I think many women, right, they feel self-conscious talking about it. They probably don't seek a lot of help. But actually, it sounds like in most women, would you say that when they are treated locally with this, that it resolves? Like, can they return to normal bladder function, normal sexual function?
Yeah, I mean, it depends on how long-standing it is. If the nerves have regressed, it may be harder to get all of them to come back to the clitoris and the crura of the clitoris and the labia. But yeah, I want women to feel really hopeful and empowered about this. And when I say that we have to rebrand perimenopause and menopause, this is exactly what I'm talking about, because this is the place where feeling shy, feeling like, oh, I've got this male GP, I don't want to talk about my vagina with him. Like, that's what we have to change. Like, let's talk about our vagina. We've got to do it. Especially if we want the quality of life, kind of the fullness and richness of life, particularly in the second half. We've got to be talking about these things.
100%. 100%. I love that you're saying that. And I think so many women, unfortunately, get dismissed. When you're
we have to train the doctors too. We have to train the doctors because, right? Because they're embarrassed also. And that's what we got to change. We got to make it really comfortable and easy to talk about this. I mean, one of the ways you can do it, this is really simple. Have a questionnaire for every woman over the age of 35 or all women and just ask them these questions. How are your orgasms? Are you satisfied with your sex life? Are your orgasms less strong than they used to be? Are you noticing more bladder infections? Do you feel like you've got vaginal dryness? Do you feel like you're irritated when you have sex, when insertion happens? So, yeah, there's lots of ways around this. Let's not just ignore it and sweep it under the rug. Let's address it.
Yeah, absolutely. With that, when you're looking at those symptoms in women, I'm curious, I think the women listening to this will be wondering, like, if they haven't experienced this, at what point they might. Do you tend to see these types of symptoms closer to menopause or like early postmenopause, or also in the early stages of perimenopause?
I see it at all stages. So classic is that, we talked about that first half of perimenopause where progesterone's low and estrogen is fluctuating wildly and how that affects the immune system. You tend to see less vaginal dryness, bladder infections, less strong orgasms in that period. It's more in the second half when progesterone's low and estrogen is low. That's when you typically see more of these symptoms, but not always. I mean, as I said, we've got millions and millions of women who take the birth control pill, and they're especially embarrassed about asking about vaginal dryness because they think it's a menopausal problem. They're like, why do I have this? I'm embarrassed to even bring it up with my doctor. But the very reason they're on birth control pills most of the time, is to have sex and not get pregnant. Like, their libido is low. It's the greatest irony, right?
I know, it's I remember taking it. It's the greatest irony. You're taking it so you don't get pregnant, but you can still have sex, and now you don't feel like having any sex.
Yeah, it makes no sense. Yeah, this is an example of a pharmaceutical that causes hormone disruption. And, I prefer other methods of contraception that are frankly more effective and don't affect your hormones.
Mm. In relation to then, if we go back, so perimenopause, if I want to talk about the early stages, one of the questions I've been asked by my community, because this isn't super common in the UK, is progesterone only therapy, and that when that would be an appropriate time. So like if a woman's still having a menstrual cycle, do you then cycle it on just the last 2 weeks of the month? And I guess for women listening, like how do they know at what point they should be talking to their doctor about hormone therapy?
Well, I would say start as early as possible. I've got two younger sisters. One is in her early 40s, and the other one is about to turn 50. And they asked me this question, like, when do you do a baseline test of your hormones? And my answer is do it as soon as possible. Ask for a baseline test when you're in your 20s or your 30s or your early 40s before things start to change. So with progesterone only treatment, I've been doing that for a few decades. And when you think about the physiology, when someone has low progesterone in that first phase of perimenopause and their estrogen is fluctuating wildly, when you give a little more progesterone, when you augment the progesterone that they're making already by giving it, as you described, for 14 days out of the month, it allows them to have a more thorough period, so a more regular period. Especially, one of the things that we talked about was that the periods can get closer together. So if you're a 28-day person with your cycle, it might go down to 23 days, 22 days. And with progesterone therapy, we can lengthen it again. We can get it back to where it was before. So part of, what's the root cause of this? The root cause is that you're running out of ripe eggs. And so the eggs that you produce that ovulate, you end up not having the same high level of progesterone that you might have had in your 20s. So you can augment it by taking progesterone. Here's where I recommend only bioidentical progesterone, so micronized progesterone. It's pretty easy to get. It's a generic. It's not patented because it's exactly the same as the progesterone that you make. I do not recommend synthetic progestins. That's what's in the birth control pill, and it's what a lot of conventional gynecologists and women's health physicians prescribe. But we think that the progestin, the synthetic progestin, is associated with a greater risk of breast cancer, not the micronized bioidentical progesterone. So with giving progesterone only, I do that when a woman is still cycling. I typically test hormone levels. So I look at estrogen, progesterone, testosterone, cortisol, DHEA in the blood. I also do urine testing because it's more comprehensive, because I'm looking at metabolites and precursors. And if someone is still making a fair amount of estrogen or it's fluctuating, then I'll just start with progesterone. And we know from the PEPI trial that when you treat with progesterone, it improves sleep and it has basically no adverse effects on your cholesterol or your cardiovascular health. So in my mind, there's no reason not to give it, especially if it helps a woman sleep. Because you can imagine if we take a look back here at these dynamic changes in your psychology, your immune system, your nervous system, your endocrine system, these gigantic changes. What we want is we want a woman to sleep well through this period, because sleep is as close to a panacea as we have. It's when all the growth and repair hormones are made. It's when you recover from the damage of the wear and tear hormones, like the stress hormones, cortisol. So sleep is essential. If women start to sleep poorly because they don't have enough progesterone and then they don't have enough estrogen, they start to fall down this hormonal flight of stairs. And that's what leads to a greater risk of cardiovascular disease, metabolic disease, immune system dysfunction. So sleep is really critical. And I would say progesterone is probably your number one tool for sleeping better.
Have you found, I have a question actually from one of the doctors in my community around some women finding it difficult to tolerate progesterone. Have you found that at all? And how have you kind of got around it?
What I find is that women don't tolerate synthetic progestins well. So there's a lot of adverse effects from the synthetic progestin in the birth control pill. Women get moodier, sometimes depressed. And that's true not just for the oral contraceptive, it's true for Depo-Provera and for the ring and the patch. So it's mostly the synthetic progestins that have an adverse mood effect. But there are some women who have an adverse mood effect from taking bioidentical progesterone. So in that situation, what I'm looking at is the upstream causes of the mood effect. So we know, for instance, more inflammation in the body is associated with a greater risk of depression and mood effects. We know that estrogen has a pretty strong mood effect that's positive. So if I have someone who's in perimenopause and she's got depression, the first thing I'm going to do is put her on an anti-inflammatory diet, and I'm going to start progesterone, and then I'm pretty quick to add something like an estrogen patch, a bioidentical estrogen patch, because it's got such a mood effect in perimenopause.
Okay. Even if she's still having a cycle at that point.
Even if she's still having a cycle, sometimes that takes some futzing to try to get the timing right. But even if she's still cycling, because of the benefit to mood, I think it's worth it, because we know that estrogen's involved in serotonin. Serotonin is, involved in sleep, mood, and appetite eating. And so when women are chronically stressed, they've got less serotonin, maybe estrogen's fluctuating wildly and they're really feeling it when it's on the low side. Sometimes a patch can kind of take that floor of their estrogen level, bring it up a little bit. I'm not talking about a high dose patch, like 0.0375 milligrams. So just enough to help with mood.
Okay, got you. And I want to come on when we talk about trauma in relation to depression, because I think it's super interesting. Are there women, for example, some women listening to this, they may have had a family history that means they can't, or they don't feel able to use hormones. Are there women that you think in the Western society who have high stress in their lives can make this transition effectively without hormone therapy? And if so, like, what can women be doing to help themselves, if you like, in their approach?
Yeah, it's a great question. So I've got lots of patients who don't take bioidentical hormones, even though I am a self-professed zealot of hormone therapy in women. So what I see is that women who really prepare for perimenopause and menopause, who are really on top of their food plan, who are keeping their glucose stable, maybe even wearing a continuous glucose monitor, which is something I do. Those are the women who often don't need hormone therapy, or they need a very low dose for a shorter period of time. So I would say preparation and then lifestyle management. So the women who have a regular meditation practice or some sort of mindfulness practice, maybe they, ideally they do it every morning. It's part of their morning ritual. They combine that with regular exercise, and it's a top priority. I especially find that women who do strength training, especially with heavy weights, and pay a lot of attention to form, and they're getting the appropriate food plan to go along with that. They're getting sufficient protein and fats and carbs. I find that those are the women who tend to do the best. So I wear a continuous glucose monitor. I've had one for going on 6 years now because I find it so helpful. And I lift heavy because I think that's just an important part of aging and keeping your muscle mass, preserving it, and even growing it as you get older. So I think that those are the women who tend to do the best and don't need hormone therapy.
I love using a CGM, I must say. It started for me because having PCOS, I really wanted to get a handle on my blood glucose. Like they weren't available then, but when I was looking at having my children, I realized, like, from a fertility perspective, being better at controlling my blood glucose made a massive difference, right, to the regularity of my cycle. I wanted to ask you about that, because some of the metabolic changes, right, that we've been discussing in terms of reduced insulin sensitivity, higher levels of inflammation, weight gain, things like this. These are things that women with PCOS actually can struggle with a lot of, throughout their lives. And it being a metabolic disorder at its core is going to continue post-menopause. What are the changes? I mean, for me, the things you've talked about, controlling blood glucose, lifestyle, I like to lift heavy, I do some high intensity work. All of those things have massively helped my PCOS. But I'm curious, for women with PCOS, do they generally have a harder time going through menopause? Do they have to work a bit harder? I certainly have always felt I've had to work a little bit harder at things. What have you found there?
Yeah, PCOS is interesting. It's I wrote in my book, The Hormone Cure, that about 30%, at least of the US population, has PCOS. And that's from conversations with endocrinologists and with other gynecologists who diagnose and treat PCOS. So I think of PCOS as similar to low testosterone in men. Both of them are metabolic disorders. And there's typically a high stress load, a high cortisol load. There's often a history of toxic stress and trauma. There's dysregulation in a number of different systems. One of the things that makes PCOS harder to diagnose is that it's a syndrome. And so, you need to have 2 out of 3 of these criteria. You need to have cysts on your ovaries and high androgens and signs of that, like acne and hirsutism. You need to have oligomenorrhea, which is a period every 35 days or less often. And so there's a lot of different phenotypes of PCOS. By that, I mean the way that your genes interact with the environment. So there are women who've got insulin resistance with PCOS, but not all women with PCOS have that, right? It's somewhere around 60 to 70% have insulin resistance. And that's a situation where finding your carb threshold using a continuous glucose monitor can be so helpful. And then there's women who are metabolically somewhat normal, but they've got the anovulation. Maybe they've got acne and hirsutism, and they've got a string of pearls on their ultrasound looking at their ovaries. And the treatment for those women is a little bit different. Sometimes inositol is a really good intervention. Berberine can help with regulating the menstrual cycle. I also look at the microbiome in my patients with PCOS. So with PCOS, what I think is curious about it is that women wait so long to get diagnosed correctly because it's a syndrome. And sometimes they can wait up to 7 years before they get a correct diagnosis. We've got to change that. This is a place where they're utterly failed by the conventional medical system. So there's a lot of different treatments out there. It kind of depends on your constellation of symptoms. But I definitely see that probably because of the stress load and the way that the control system for your hormones, and by control system, I mean the hypothalamic, pituitary, adrenal, thyroid, gonadal, gut axis. It's kind of a mouthful, but that's the control system. The control system is just wonky in PCOS, and it leads to these different clusters of phenotypes. And so you really have to understand what's going on personally with the person in front of you, rather than a blanket statement for, one size fits all in terms of treatment.
So this is really interesting that you mentioned that, because I remember having a conversation with Dr. Libby Weaver, who wrote Rushing Women's Syndrome and various other books. And when she was talking about PCOS, she has observed that women with PCOS often had a very dominant father in their lives. That was something she'd observed, which I thought was super interesting.
It is interesting. And I was just on a podcast where the host was asking me if I thought that our patriarchal culture is forcing women to be more in their masculine, and if that is part of the root cause behind PCOS. And I don't have an answer to that. I'm not a medical anthropologist, but it's a curious question. It's a curious question. And I think that might link to the hypothesis that you're mentioning about, having a dominant father. So then, of course, I want to ask you if you had a dominant father and what you think about all of this.
I did. It resonated with me. I did, and it's really interesting because I also think, and we can talk about this when we talk about trauma and depression and things. So I had just very, I guess, interesting journey along this line. I did have quite a dominant father, and I was a real daddy's girl. But I also wonder whether familial position plays a part in this. So I was the middle child and quite like naturally academic, sort of easy, parents didn't really need to worry about. And I definitely modeled around my father and felt that I had to be that strong person. Do you know what I mean? And much more like him. And it was sort of weak to cry and things like that. So it was really interesting. But I was definitely failed by the system, as you were speaking about. So for me, as a teenager, it was like, never diagnosed. It was just like, hey, you know what? We have an easy fix, birth control. Here you go, from 15. And when I interviewed Dr. Sarah E. Hill, it was fascinating learning about her research in the way it affects the female developing brain and your risk of major depressive disorder later in life, which I then had later in life. So and it definitely, the system let me down until it got to the point where I wanted to conceive a child. And it was like, well, how am I going to do that with no periods? Do you know what I mean? There's no menstrual cycle. That's not going to happen. And that's when I had surgery and it was discovered I had PCOS and endometriosis and had to sort of fix that. But yeah, it is quite interesting, I think. But I also wonder, I think there's probably a number of factors at play, right? In terms of that psychology of that woman growing up, maybe.
There's a number of factors. I mean, it's birth order, I think, could also be a factor. I don't have PCOS. I've got a lot of people in my family who do have PCOS. And as you describe this, I'm thinking about their fathers and how dominant they were. And there does seem to be a correlation. So I'm the firstborn in my family. And I think that leads to a different set of circumstances. Definitely it can lead to an overachiever, kind of, what did you have to do as a kid to get the love and attention that you wanted and deserved? That's always a question that I like to ask. And for me, it was academic achievement. It was just a way for me to, try to reduce the volatility in my household and make things more predictable and try to smooth things over. And then what does that do later on in terms of midlife and symptoms that you might experience? You mentioned depression. I also had depression starting in my 20s. I had postpartum depression after my first child. And I mean, a lot of these are subtle environmental cues that mix with your genetics and lead to a particular set of conditions later on, like PCOS, like depression, like post-traumatic stress disorder, people pleasing, autoimmunity. We know, for instance, that adverse childhood experiences is associated with about 45 different chronic diseases in midlife, one of which is autoimmune disease.
Which we're going to come on to talk about in part 2. Before we kind of close out on the hormone side of things, I would love to touch on postpartum depression. It's something I had 3 times over. What do you think's going on there? How much of that is hormonally driven? There's obviously a big environmental impact, right? There's new stress in that woman's life. It depends how well she's supported. I'm curious what you found and any kind of nutrient insufficiencies and things like that that might also contribute.
Yeah, this makes me get a little misty because I felt so isolated after I gave birth to this beautiful daughter of mine who's now 24. And I think there's biological reasons, and then there's more gendered, socially constructed reasons for postpartum depression. If we just start with the hormones, women go from having sky-high hormones, estrogen and progesterone, during their pregnancy. So a lot of women feel and look their best, like they've got that pregnancy glow, because their estriol, the main form of estrogen during pregnancy, is so high. Their progesterone is so high. And then when you give birth, you deliver this beautiful baby, you deliver your placenta, and your hormones go from sky high down to almost nothing. So that's a pretty dramatic change. And
huge.
It's a preview of coming attractions in perimenopause and menopause. I think it's really important to understand that. And so some women navigate it just fine, especially the women who've got a lot of support. You know, maybe they've got a mother, grandmother who's helping them. They've got a village. They've got like a mom's group that they go to. They've got the support to be able to sleep at night. So some women do just fine with that. Other women really struggle. And I remember, you know, like day 3, day 4 after giving birth to my first child, I'm lying in bed breastfeeding. And I just have sweat just like coming off of me. The room is kind of cold. I keep it around 64 degrees. And I am sweating profusely. And I'm a gynecologist. And I'm looking at this in myself and I'm like, oh my gosh, I'm having a hot flash. I'm having night sweats. Like it took that happening to me to kind of put it together. Oh my gosh, this is a menopausal state to be postpartum. So there's a massive hormonal change. There's also this massive psychological relational change that happens where, you know, if you're in a couple, your couple goes from 2 to 3. It's a big change psychologically. Some people navigate that really well, other people not so much. There's the sleep deprivation. There's, you know, the anxiety of caring for a being that's utterly dependent on you. There's all of that. You know, I had this feeling of, I want to be a great mom. Like, I really want to co-regulate this beautiful baby. I want to do everything I can for her to feel safe and secure. And it's a lot of pressure, right? And it's kind of the first time for many of us where we start to sacrifice our own self-care to take care of this baby, which is, you know, in many ways necessary and kind of the way it goes, but it can be rough. It's a big transition. And then there's this more socially constructed gendered side to it, where I'm no longer in this marriage, but in my marriage, my husband at the time expected me to do all of the childcare. And, you know, I went from working full time to going on maternity leave 1 week before I gave birth. And that was rough. That was really rough, you know, to not share in the infant care and child rearing. So there are ways that, you know, especially in the US, I don't know if this is as true in the UK, you can tell me, there's a lot of isolation. So I think all of those conspire to lead to a greater risk of postpartum depression. I also think that any woman who's got the blues or signs of depression should have her thyroid checked, as well as her other hormones, because postpartum thyroiditis, development of autoimmunity, is really common. And then when you are aware of this, you can also change things. So I can tell you, with my second baby, I had my first baby at 32, my second at 38. With my second baby, I knew all of these things. So I was on top of my game in terms of exercise and support. I had my mother there to help me. I did baby boot camp. I did a second time mom's group. I didn't do a mom's group with my first baby. And I did not have any of the mood effects that I did with my first. Now, I understand that wasn't your story. I want to hear a bit about your story. But I just want to empower people to realize that these are things that you can change when you know about them. Knowledge is power.
That is so good to hear, because I think so many women, it is, in answer to your question, it is the same in the UK. And I think because we don't have that village anymore, right? Often grandparents are not close to us. We've moved away, and people are just, a lot of people are so more educated, right? They've gone off to universities in different parts of the country, and then they've moved. And I think they don't have that support. I think for me, sadly, actually, I did put in place more and more infrastructures to support. But what I found was it got worse each time, and it became more entrenched. But that may be because I ended up with major depressive disorder at a later date, which then went on for a number of years. So it could be different. I think for many women, that level of support is probably very helpful, and also the sleep makes a big difference, right?
For sure. Yeah, it's, when we talk about scientific evidence, there's a hierarchy. And with, what I'm describing, having postpartum depression with my first baby and not with my second, that's expert opinion and it's anecdotal. And that's considered the lowest quality of evidence. But the highest quality of evidence is the randomized trial. And we don't have enough of them postpartum to really see what works. And then above that, at least what I was taught at Harvard Medical School, is the N of one experiment. And that's when you try different things, like reducing inflammation as a way of trying to lower your chances of developing major depressive disorder. One of the things I run in all of my patients is a genetics test, a pathway-based genetics test, so that for people who've got a tendency toward depression or have a history of postpartum depression, so that we can find some of those root causes, those upstream causes that might lead to a diagnosis of postpartum depression or major depressive disorder. And we can do something about them. We can work around some of those genetic risks so the environment can fully support you as the individual.
And what would some of those genetic risk factors that you found, what would they be?
Yeah, so there's a lot of them. With the kind of test that I run, I'm looking at cellular processes first, and that includes methylation, inflammation, oxidative stress, kind of the rust in the body just as a result of living, and detoxification. So those four pathways can contribute to depression, postpartum depression, major depressive disorder, especially the inflammation. So I look at those genetically, and then I run blood marker testing, blood work, to put it together with the genetics to see what needs to be optimized. The other thing that I see is, methylation certainly is another important factor when it comes to depression, and it can make a big difference to be getting sufficient methylated B vitamins like B6, B9, B12.
That has always made a big difference to me.
Yeah. Makes a huge difference. Vitamin D is really critical. It's got 400 jobs in the body. You can look at oxytocin, the single nucleotide polymorphisms related to oxytocin. You can look at estrogen and how it's metabolized. You can look at testosterone, how much aromatizing there is, conversion of testosterone to estrogen. Inflammation affects that too. So those are some of the factors that I look at in terms of the risk of depression.
And when you're testing for inflammation, for people listening, what tests are you running to identify inflammation in the body?
So I'm looking at genetic markers, things like C-reactive protein. And then in the blood work, I'm looking at a number of different things. There's kind of a basic panel that we look at with high sensitivity C-reactive protein. So we're looking genetically and then also at the blood for the same pathway. And then I also look at if I'm concerned about autoimmunity, and I'm concerned about that because a third of the population has it. If I'm looking for autoimmunity, I also run a set rate, also known as ESR. I look at complete blood count with differential, CBC with the diff, looking at the neutrophil to lymphocyte ratio, and then more advanced testing. This is more in people who are older or they've got cardiovascular risk factors. We can do some additional tests that are specific to inflammation inside blood vessels. I also look at homocysteine, which tells us about methylation and about the status of B vitamins.
Awesome. And where can people find out, before we kind of close on hormones, where can people find out more about this? Would this be your book, The Hormone Cure? What would be the best resources or how they can connect with you in relation to this?
The Hormone Cure is the best place to learn more about this particular information. So that's my first book. It still has stood the test of time. All the recommendations in it are based on randomized trials. And if you want to interact with me on social media, I'm mostly on Instagram at Sara Gottfried MD. And my website is saragottfriedmd.com.
Amazing. Thank you, Sarah. We will link to all of that in the show notes.